Sunil Choudhary, Professor Sunil Choudhary, as the next speaker. He is from the Department of Radiotherapy and Radiation Medicine, Institute of Medical Science, Banaras Hindu University, Varanasi.
Esteemed Chairperson, faculties, delegates, ladies and gentlemen. I am Dr. Sunil. I work as a radiation oncologist in Department of IMS BHU Varanasi. This study was conducted in our department by one of our MD students as a thesis work. So we tried to compare two radiotherapy techniques where IMRT was used in both the arms in head and cancers. So before I discuss in detail about the study, I would like to give you a brief outline about radiotherapy, because I can see in the audience none of you are a radiation oncologist except one who is still my student. Just to say something about the incidence of the burden of head and cancer. Globally, head and cancer is the sixth leading cause of cancer, with new cases about 650,000 per year, and 50% of these patients dying annually. And India, it ranks the most common among the males and fourth among the females, with an incidence of about 10% annually, and about 50% of patients dying as a result of the disease. So just to start about the outline of radiotherapy, so that you can really understand what I'm going to talk about. We can divide radiation as non-ionizing and ionizing. This is the spectrum where the visible light, the radio waves, the microwaves, the infrared, these are the non-ionizing radiation. They're not harmful and they don't cause cancer. While the ionizing, like X-rays and gamma rays, these are used for treatment of cancer, and they are harmful as well to the normal body. The main action of X-rays and gamma rays is on the DNA. They damage the DNA, and it's the damage of the DNA which results in the death of the cancer cells. And mostly it's due to the indirect effect where the water molecules react with the X-rays and the gamma rays, and it's the free radical which is produced which really causes the damage to the DNA. Usually what we do when we treat the patients with radiotherapy is not given on a single day. The patients are treated over a period of 5 to 7 weeks usually. Like in head and neck, the treatment is for a period of 6 to 7 weeks. So we treat the patients 5 days a week. So like if we start on Monday, so one fraction a day, and again it's repeated on the second day, and so it's 5 days a week, and then Saturdays, Sundays, the patients are not treated with radiotherapy. Then again, the same procedure is repeated in the next week and lasts for usually for 7 weeks. Now, if we complete the treatment in less than 7 weeks, we call it accelerated radiotherapy. Whenever we accelerate, it speeds up, the speed accelerates, and therefore the treatment duration is less. So there is a rationale for why we do accelerated radiotherapy in head and neck, because these cancer cells, they divide at a very fast pace, and so whatever the cells get killed on a particular day, they again repopulate, and there's a loss. So in order to cover that, the radiotherapy needs to be completed as early as possible. So there are 5 hours of radiobiology which we exploit to get the benefits of these 5 hours. One is radiosensitivity. Radiosensitivity is something which is innate, which cannot be is inbuilt. Like there are few cells which are very radiosensitive, and there are few cells in the body, like few tumor cells which are very radioresistant. If you talk of glioblastoma multiforme, the brain tumors, the high-grade brain tumors, these are radioresistant tumors. But if you talk of germ cell tumors like seminoma, they are highly radiosensitive. Even a dose of 20 gray melts the tumor. But in case of GBM, even a dose of 70 or even beyond that doesn't do any harm to the tumor usually. The second R is repair, where we give sufficient time between fractionation, like as I mentioned in the previous slide, like we give one fraction a day. So this is given for the repair of the normal tissues. The normal tissues as well, they get damaged with radiotherapy, and if you give sufficient time of at least 6 hours, they get repaired, and therefore the toxicity with radiotherapy is lessened. The third R is repopulation, where, as I talked, we need to accelerate radiotherapy. If we allow the tumor cells to repopulate, that the local control is ultimately going to fall down. So we have to create a balance, and the treatment duration should be as minimum as possible. The fourth R is redistribution, where we allow the cells, like in every cell is in a different phase of cell cycles. Many of these would be in G1, the few of these would be in S phase, some would be in G2 M phase. So G2 M phase is considered to be the most radiosensitive phase, and the S phase is considered the most radio-resistant phase. So if we treat the patients, give a single fraction a day, and then allow few hours, like at least 6 hours or beyond, for the cells to redistribute or reassort. So we allow the cells to come in the radiosensitive phase and they get killed. The fifth is reoxygenation, where because the tumors, they grow at very fast pace, the vascularization is not able to keep up to the pace of the tumor growth, and therefore in the center part of the tumor there is hypoxia or anoxia, and in the peripheral part there is the cells are oxic. So once we treat once we give a fraction of radiotherapy, the outer cells, they get killed, and then this allows the cells which are inert to get oxic. So the fractionation helps in reoxygenating the tumor cells. How is radiotherapy done? Usually there are two procedures. One is the external beam radiotherapy, the other is brachytherapy. In case of external beam therapy, like these are two machines, where this is a telecobalt machine where there's a radioactive source which is cobalt. So the radiation comes from a distance from the body. Like as you can see, this is the gantry, and this is the head where the radioactive source is placed, and the patient lies on the couch, and the radiation, the gamma rays, will come from the radioactive source. So it comes from a distance, at least say a distance of 80 centimeter beyond. And this is linear accelerator where X-ray is produced, same as here. This is a gantry where the X-ray is produced. It's a linear accelerator. The electrons, they accelerated, and they strike a target which is tungsten, and then X-ray is produced. And the X-ray hits the patient at the specified area or the volume, and the cancer cells, they get killed. And this is an afterloader, where brachytherapy machine, where the radioactive source in the form of iridium or cobalt is sourced inside, and this machine is connected to the tumor with a transfer tube, and an applicator is placed in the tumor, and that applicator is connected with the transfer tube to this machine, and the radioactive source will traverse through the transfer tube through the applicator into the tumor. And so in this case, the tumor and the radioactive source, they are in close vicinity. So that's why it's called brachytherapy. Brachios means near, tele means far. So one is the teletherapy, where telecobalt machine or linear accelerator is used. The other is brachytherapy, where afterloader brachytherapy machine is used. This is the workflow in any radiotherapy department. It starts with a consultation in the OPD, and after the diagnosis made of the staging is done, complete staging, we decide. It's a teamwork. We decide with the surgeons, with the medical oncologists and the radiation oncologists together, what is the ideal treatment, standard treatment for this patient. And based on the decision, the patient, if it's decided to take the patient for radiotherapy, the patients are simulated. Simulated is like we try to plan out how the radiation has to be done in a particular patient. So imaging is done, like CT scan, MRI, different PET CT. These images, they are fused together on a treatment planning system, and the target, the volume, the target which needs to be treated, the tumor area, the tumor volume, along with those volumes, those organs which are adjacent to the tumor, which we call organ at risk, they need to be delineated so that the computer knows these are the organs which need to be spared, and this is the target which needs to be targeted. This is the volume which needs to be targeted. So this is called as contouring, which is done on a treatment planning system. And then we give our contour to our medical physicists who plan. They do the planning, apply different sort of beams at different angles using different parameters. And after the planning is done, this needs to be approved and evaluated by the radiation oncologist. And after everything is successful, the radiation is delivered on the machine, either a linear accelerator or a telecold machine or a brachytherapy machine. And then after the treatment is completed over a period of 6 to 7 weeks, the patient kept on follow up to see the progress of the disease and if there is any recurrence in a long term. As I talked about the volumes, there's something called GTV, which is gross tumor volume. Like if you can see in this picture, this patient has a disease of the tongue, and this area which is marked by red is the gross tumor volume tumor. T stands for tumor, and the patient has a node, neck node, which is also marked in red and we give a name of GTVN, gross tumor volume node. So this is the, as you can see, this is the GTV, and this is the volume which needs to be targeted. Like this volume should get 100% the dose which is prescribed, and around this volume of GTV there is something which is called subclinical disease, like which cannot be appreciated on CT or MRI or in clinical examination. So but still the disease is, the cancer cells are there in minute numbers which can be appreciated only on a microscope. So that is a subclinical disease which we call clinical target volume. So the area marked in yellow over here is the clinical target volume, the CTV. So there would be a CTV around the tumor, primary tumor. There would be a CTV around the node as well. And around the CTV, this is the GTV, and then there's a CTV and expansion beyond that. And since there would be, because the patient's treated over a period of 6 to 7 weeks, there would be setup errors on a daily basis. There would be organ motion, like if suppose the disease is there in the lung keeps on moving with every respiration. So there has to be some an extra volume, extra margins given around the tumors, so that the tumors, they don't get missed when we treat. So that is the planning target volume. That is safety margin beyond the CTV. So we usually target, the PTV is targeted. There are different techniques, as I said, this study was based on IMRT. So there's something which is very conventional, which is two-dimensional, which is based on the bony landmark. So in this case, the field is quite large. The organ at risk will get a higher dose, as you can see, appreciate on this. So it's basically a simple design of the radiotherapy portal, and it's based on X-ray and the surface marking and the bony landmarks. And if we start conforming to the disease, to the volume, so it becomes conformal radiotherapy. So if it is done in three-dimensional, if it is based on image like a CT, MRI or a PET CT, so it becomes three-dimensional, where as you can see this, just a represented diagram, where, is it done? Sorry. So it becomes three-dimensional, and then if the intensity within the field is changed, it becomes IMRT. So I have to rush because. So as you can see in this picture, this is the gross visible, which is the GTV. We give a margin of 5 millimeters. It becomes CTV high risk, and then again a safety margin of 7 mm. It becomes a PTV, planning target volume at high risk. Similarly, additional margin to CTV HR, and then further margin makes it PTV IR, and again this is the low risk volume, which also needs to be treated with a margin, safety margin. It becomes a PTV LR. As you can see, this is what the study was between sequential IMRT and smart simultaneously modulated accelerated therapy. In this case, it's a sequential as the name suggests. It's sequential. In the first phase, we give a 50 grade 25 fraction over a period of 5 weeks, and all the 3 volumes are to be treated. Then in the phase 2, the high risk and the intermediate risk is to be treated to a dose of 10 grade 5 fractions, and in phase 3, only the high risk is to be treated. As in case of smart, like everything is served in a platter in a one go. So the entire volume, though there are 3 volumes, all these 3 volumes will receive the different dose, a differential dose at the same time. The treatment is completed in the same duration. So the advantage of smart over the potential advantage of smart over sequential is that it's a composite plan and the shorter duration of radiotherapy. As in case of sequential is over a period of 7 weeks. In this case, it's over a period of 6 weeks. The objective was primary objective was local control, DFS, OFS, and the secondary endpoints were acute toxicity and late toxicities. Inclusion criteria all confirmed: squamous cell carcinoma of oropharynx, larynx, hypopharynx, age between 18 to 75 years, good KPS, stages from 2 to 4A, consent of the patient, of course. Patients were simulated on a CT scan with 4 clamp thermoplasticas. You can see the thermoplasticas. This helps in the patient, keeps the patient immobilized. And the patients were treated on 6 MV lean accelerator, and this was a simulator where this is a CT simulator where the patients were simulated, and the patients were given cisplatin concurrently at a dose of 35 milligram per meter square once a week. If you compare these 2 arms, the demographic profile of the patients, the tumor characteristics, they were not. The difference was almost non-significant except for the stage. Analysis was done on 1st of December 2023. The median follow-up was about 4 years in both in the smart arm, and about 2.5 years in the sequential arm, with median follow-up of those who were surviving was around 5 years, more than 5 years. And at the time of analysis, it was seen that patients who were dead due to disease were 5 in the smart arm and 8 in the sequential arm. And this is a pattern. Only 1 patient had a local failure in the smart, and 3 patients had distant failure in the sequential. If you can see this, most of the patients were in 4A, stage 4A, and 18 patients were in 4A. We did a univariate analysis to evaluate if the factors which were responsible for the prognosis, and we could see that we could analyze for age and those patients who had RT versus chemoradiation, and it was seen that they were not significant. This is the Kaplan-Meier plot for DFS. The mean DFS for the study was 57.5 months. Mean DFS was 43.1 months for smart arm and around 42 months for the sequential arm, and it was non-significant. The OS was 39 months, the mean OS, and 5-year OS in the smart was 40%, while it was 27% in the sequential arm. The acute and the late toxicities were not significant in both the arms. So the take-home message is smart is better than sequential IMRT in terms of survival, with no difference in the toxicities. Thank you so much.